Hi everybody, I'm Dana Byrne. I'm one of the infectious disease physicians at Cooper.
And I'm Lucia Rosé, infectious disease pharmacist.
And we're here because we're talking to everyone about CDC Antibiotics Awareness Week. This week is CDC Antibiotics Awareness Week, where we're talking about antibiotics and what the appropriate way to use them and why it's important to preserve them for when we really need them. To prevent antibiotic resistance and also to prevent side effects and adverse events from happening to you. I think we're going to answer some questions that were submitted we do have an audience here, and we're also answering questions that are submitted online, so feel free to submit your questions while we're talking about the other questions that have already been submitted.
All right, so I think first we should talk about the reality that a lot of providers get pressure from antibiotic prescribing or give pressure to their providers to get an antibiotic for certain indications. And the reality is that a lot of viral infections can make patients feel really crummy, but that doesn't usually necessitate an antibiotic. Things like sinusitis, just your regular common cold, even pharyngitis, or a painful throat when it's not due to a certain bacteria doesn't require antibiotics.
Yeah, and the color or the amount of mucus doesn't matter. That doesn't necessarily mean it's a viral infection over or a bacterial infection over a viral infection. And antibiotics don't work against viruses, and that's the most common cause of all these ailments. Sore throats and runny noses and sinusitis are often caused by viruses instead of bacteria, and your antibiotics aren't going to help with that. But what can happen is over time, bacteria can become resistant to antibiotics. So the more that you get exposed to antibiotics, the less likely they are to help you when you really need it.
So we're encouraging patients to really instead of, if the provider chooses to not give you an antibiotic, to instead listen as to why that antibiotic might not work and instead do other things that will help. Things like over-the-counter Tylenol or decongestant like Sudafed can really help in some of those upper respiratory infections.
Right, symptomatic-based treatment is important because the antibiotic itself isn't going to make you feel better either. Usually what happens is if people feel that they're getting better from a viral illness when they take an antibiotic, it's usually because the viral illness is going to get better anyway. So with time, everybody gets better, but we can give you solutions to try to make you feel better in the meantime. So like Dr. Rosé was saying, decongestants, cough medicines, things like saline rinses and vaporizers can really help. So your doctor may suggest using those things to make you feel better since the antibiotic isn't going to work anyway.
And some of the things that we're seeing in the hospital and have been for the last 20 years but has actually gotten worse is a lot of antimicrobial resistance. So as patients get more and more antibiotics over time, we're losing some of our first-line choices for a lot of our patients, and a lot of times this affects hospitalized patients. So in other words, if you continue to get antibiotic prescriptions over your lifetime, you're more likely to have a resistant organism when you do have a bacterial infection and actually do need an antibiotic.
And there are infections that can happen from using antibiotics too much as well, things like Clostridium difficile or C. diff for short. You may hear about in the news is a type of diarrhea that can be brought on by antibiotic use. And we're seeing more and more cases of that come from the community, meaning that people are getting the antibiotics from their outpatient doctor, or they're taking antibiotics that they had for something else for a condition that's not really, that doesn't really need antibiotics. And then they're coming in and getting sick from this. And unfortunately, it can cause a lot of, pain and discomfort. And sometimes, even colectomy is necessary to cure that. So we obviously don't want that to happen.
Yeah, I think another good example of unnecessary antibiotics that we see a lot of times in the hospital is patients or family members that associate certain infections with sort of generalized feeling, sort of like altered mental status, or and so sometimes we have family members that come to the hospital complaining that their mother or their grandmother, every time they get a certain infection, like a urinary tract infection, they have those symptoms or signs. And so oftentimes they're started on antibiotics, assuming that that's what the infection is. And in reality, they may have been dehydrated or needed electrolyte replacement or something like that.
Yeah, and we do see a lot of, even on the outpatient side, for urinary tract infections, it's pretty common for, especially in women, for bacteria to be in the urine in general. So, just because there's bacteria in the urine doesn't necessarily mean that you need an antibiotic to treat you. Really, it should be based on symptoms like burning or pain or fevers, something like that. Just because we find bacteria in a urine culture is actually not a reason to treat it unless the woman is pregnant. That's one exception.
Yeah, so that definitely drives a lot of unnecessary antibiotic usage in the hospital because there are so many positive urine cultures.
Yeah.
So what types of things are you looking for when you assess a patient to determine whether or not they're a candidate for receiving antibiotics, or you would recommend a different course of treatment?
Yeah, so in the outpatient setting, it always depends on what condition we're trying to treat. So for respiratory infections, for instance, by far most of them are viral, and the antibiotics aren't going to help for viruses. But what we do look for is we look for warning signs, and usually that's based on how long the symptoms have been going on, because most symptoms, if they're caused by a virus, should start to get better in about a week. If symptoms are persisting for over a week to 2 weeks, we start considering that it could be due to a viral infection. And like I said, the color or the frequency of mucus doesn't help us. Any bug can do that, a virus or a bacteria. The height of the fever doesn't usually help us because viruses can cause high fevers, especially in younger people. And so, we basically have training based on what the patient looks like. And if the patient otherwise appears well, but has, a little bit of fever or some mucus or, a sore red throat, usually in most cases that's a viral infection, and we would recommend waiting unless the symptoms persisted for a longer period of time. In terms of other conditions like urinary tract infections, like we said, it's very symptom-based. So if the patient's having classic symptoms of a urinary tract infection, burning, pain, frequency, especially if they've, experienced urinary infections in the past and they know what it felt like then, sometimes we'll diagnose that just on clinical factors, just on their symptoms. And obviously we'll do a culture to follow up and make sure that the bacteria is sensitive to that antibiotic. But there are other things, that can cause similar symptoms that we obviously take into account. For instance, there are sexually transmitted infections that can cause symptoms similar to urinary infections. Sometimes there are, irritants or contact problems that can happen. So, it's important to have the doctor or the provider, listen to the history so that we can make the right diagnosis.
Yeah, and I think in terms of respiratory, it is challenging for providers sometimes to come up with that diagnosis, since there's sometimes other than a good lung exam and imaging, which isn't something that outpatient providers have all the time, it can be really challenging for providers to diagnose. I'm not a provider, so that's, but in terms of just having, read a lot of the literature and talking to providers, it can be really, really challenging to come up with that diagnosis. So a lot of times, they may empirically, or in other words, give an antibiotic without having a specific diagnosis. But one of the things and this is more for providers and sort of even the general public to understand, that the CDC is now recommending outpatient providers to come up with what's called a contingency plan. In other words, if the patient doesn't receive the antibiotic, let's say they present to their outpatient provider or an urgent care, which a lot of times these patients are seen at on day 3 or 4, the contingency plan may be, by day 10 or in a week, you're still having fevers or your symptoms actually get worse instead of get better, which is sometimes a sign that it's a bacterial infection. Then, come back and see us or call us back, and then we'll start an antibiotic at that time. But that plan actually can help patients feel very comfortable because they know that they're not just being let go to figure it out themselves. So
right. And patients, if your doctor's giving you a contingency plan, it means they're being responsible prescribing antibiotics, and you really want your doctor to be responsible when they prescribe antibiotics because you want them to work for you when you need them most. And in certain areas of the world, antibiotic resistance has gotten so bad that there are very little antibiotics left working for bacterial infections, and we certainly don't want to have that happen here. And so, it's not that your doctor doesn't want to help you, it's that they're trying to, be wise about the use of antibiotics and make sure that we're not overusing them if they feel that it's not going to help you feel better anyway.
Yeah. There's another thing I think we could talk about a lot, another sort of topic that comes up a lot in both the inpatient and outpatient setting, and that's allergy. A lot of patients state that they have a penicillin allergy but don't either remember the specific reaction, or when they were young they were told, it was a myth sort of, or a thought in the past that if your family member, your mother was allergic, that your child was also allergic, which is no longer evidence-based. We know now that that's not true. But so a lot of older patients actually may have had allergies or in their charts or thought that they had allergies, but in fact they don't actually have allergy. Or the other kind of part to that is that compounds were made a lot less pure in the older days than they are now. So we know now the general public has much less statistically numbers of actual allergies than they used to in the past.
So I always get an upset stomach whenever I use antibiotics because I'm always given really strong ones, or so it seems. So I always hear it's really important you have to finish that antibiotic prescription. But if my stomach hurts, like, why is that important to still finish out that prescription?
That's a great question. So generally we recommend finishing your antibiotic course because even if you feel better, if you don't finish the course prescribed to you, the bacteria can become resistant from your infection, and then you can get sick again when the antibiotic stops early. So that's why we recommend completing the course. That being said, there are a lot of side effects from antibiotics, and we recognize this. So if you're having trouble tolerating an antibiotic that your doctor or your provider gave to you, you should contact their office and see if there's an alternative, or if there's some way that they can come up with a compromise so that you can tolerate that antibiotic and better and finish the course so that your infection is treated. The easiest way to get antibiotic resistance is to sort of start and stop short courses of antibiotics. Because every time we start and stop, the bacteria get a little bit smarter and they get a little bit more resistant to infection. So we definitely don't want to skip doses. We definitely don't want to start and stop. We want to try to take the course as prescribed and finish it, as prescribed.
Yeah, so, as Dr. Byrne was saying, I think there are some supportive methods if you have limited choices, which some patients do. But if you're given an antibiotic for a general infection that is on the easier side to treat, there's certainly a long list of oral antibiotics some are better tolerated than others. And there's some that are class-wide, like just terrible and hard to take stomach, can cause diarrhea, nausea, vomiting. And there's some that are much better tolerated, but everybody's a little bit different. So that really does not preclude the usage of that antibiotic in the future, nor would it prevent us to use an antibiotic in that class. And that's really important. So patients that, this definitely comes up in the hospital where a patient may be confused and not remember that it was just an upset stomach. So then they're given sort of lower or inferior, not as good choices because they have quote unquote an allergy, but it's not really known exactly what happened. So it's good for patients to know if they do have an upset stomach. It's important to highlight that because that's not a true allergy. That's an intolerance.
Right. And the true allergy that we always worry about are things like something called anaphylaxis, which is a severe allergic reaction, usually requiring medical attention, meaning that the person had to go to the emergency room to be treated for it. And that's a severe and true allergy to something like penicillin. But most of the time, people's allergies are rashes or upset stomachs. Like we said, that's not a true allergy. Or they don't even remember. Someone told them they have an allergy, and that's, not, they don't even remember having the allergy. They know they weren't hospitalized. And the reason that this is important is because when we don't use the penicillin class antibiotics, the penicillins are the cousins to penicillin, people actually do worse when they're being treated for an infection in the hospital. So it's important to clarify your penicillin allergy, and if it's not a serious reaction, make sure that everyone knows.
So would you say, based on the symptoms, that there's a certain window of time that you would encourage patients to somewhat ride it out, their discomfort at home, where now we're in a place where I sort of don't feel right, I'm going to run to an urgent care and get a resolution within,
I do think that that medical care is now easier to sort of obtain than ever, which is good and bad for some reasons. I guess the bad is that there is no provider-patient relationship, so the baseline of that patient's not really known when you go to an urgent care. So that kind of leaves a lot of unknown or uncertainty to that provider. Whereas if it's a provider that's seen you for 20 years and then now sees you in the office and it's not like you usually are, they're able to make that assessment a lot sooner and with less data. But I think that the other thing about it too is it sort of depends on, well, you can definitely talk about this. I think it depends on what infection you're talking about, because if you get bitten by a cat and you have a fever 2 days later, we definitely recommend to go, actually if you get bitten by any animal, you should go immediately, and not to make light of that. But so that's a very different scenario than if you have a runny nose and some low-grade fevers from a sinus infection, So I think it certainly depends on the clinical scenario. But yeah, or if you step on, a sharp object or something, you should, and a few days later it gets infected, that's a different picture than waiting a few days because you have a respiratory infection, if that makes sense.
I think there are some conditions that really allow us to wait it out, and those things are like our respiratory tract infections. They can be viral. Excuse me. And, I think that we really try to let the patients know why we're not giving an antibiotic, and that can be something that patients can do to be, sort of to bring that education to the table. There may be a very good reason that your doctor doesn't think an antibiotic is appropriate, and it's not because they don't want you to feel better. It's really just because they think it's not going to help you, and it actually may do more harm than good. I think now in 2018, we know that antibiotics actually do a lot of harm. Not just to ourselves, but like for resistance in general in the community, but also in side effects. There's a certain, there are studies that show that, greater than a third of patients who get an antibiotic have side effects that make them feel sicker. So I do think it's important that, patients realize that it's not just because the doctor doesn't want to help. It's not that at all. It's more just that they want to weigh the risks and benefits of the antibiotics, and they want you to get well, but also do it in a way that's going to benefit you the most and have the least risk. Yeah. And it's not that you can't go to urgent care. Certainly they can give you symptomatic relief with other things, anti-inflammatories, cough medicine sometimes. They can give you advice on what to do and what to look for, if you're getting worse. They can give you a contingency plan, and all of that is good. It's just that every time a patient goes, they shouldn't be expecting an antibiotic if it's for something that might be better to watch and wait.
Right. So specifically for respiratory infections is what we're, or up chest colds and things like that is what we're really referring to in terms of the watch and wait. So, there's certain things that you shouldn't wait for, but the respiratory infections are something that the watch and wait approach tends to be recommended for most healthy, normal immune system or immunocompetent, what we would call patients.
Right, and make sure that you're, if you have other underlying conditions like COPD or, diabetes, or like Dr. Rosé was saying, compromised immune systems, you're on an immunosuppressant for psoriasis or rheumatoid arthritis or anything like that, it's a little bit different and probably wouldn't recommend watching and waiting. You should probably just be evaluated to make sure everything is okay.
And make sure you get your pneumonia vaccines for those patients and your flu vaccines, which are really, really, really important.
Yeah. They help us by keeping people out of the hospital. So even though they're not directly related to antibiotics per se, they do make people well, and they do actually prevent infections and super infections, so bacterial infections after a viral infection, and keep people out of the hospital. So it's really important to keep up on the flu vaccine and the pneumonia vaccine if you qualify.
Yeah. So talk to your healthcare provider about that, because there's a lot of qualifying chronic illnesses that actually can make you an earlier candidate for the pneumonia vaccine.
Right, like asthma and diabetes, things
Yep.
like that.
Great.
Yeah. Well, thank you guys for tuning in. We're happy to support Antibiotic Awareness Week here at Cooper. If you'd like more information, there's some links on the website, but you can also go to cooperhealth.org and look into the info we have posted there. And hopefully throughout the week, we'll be posting some links to some of the other things that we have information about. And we're so happy you could join us.
Thank you all very much.